Hello, everyone. My name is Carly Burridge. I'm the owner and founder of Gaining Health, and we're here for another episode of What's Up Wednesday. So for this episode of What's Up Wednesday, I figured I'm going to take the information from the Chicago Obesity Summit that we just had last week. It was my first in-person conference that I've had since the pandemic started. So I was super excited to be there in person. I was honored to be part of the CME committee as part of the Illinois Obesity Society. And I really have to give the hats off to our course directors, Dr. Panane and Dr. Jabbar. They really put together an excellent panel of speakers. So what I'm going to try to do is take that whole day of CME and kind of boil it down to what I thought were some of the most important takeaways from the conference. So we started off the conference with a debate about meat-based versus plant-based diets. And the speakers were both dietitians, Courtney Schuschman and Erica Batten. And so what they argued was which one was better and what are some of the benefits and some of the risks of both of those. And so as far as the benefits of an animal-based nutrition plan, the points were made that animal proteins are, of course, a good source of complete protein, B12, iron, zinc, and those are nutrients that are often deficient in people who follow a vegetarian or vegan diet. And while plant sources of protein do exist, they often have to be consumed in greater amounts and in greater caloric content than animal sources of protein. However, on the flip side, the argument was made that animal proteins may increase TMAO, or trimethylamine N oxide, which may increase the risk for cardiovascular, chronic kidney disease, and heart failure. Then they went on to say that, of course, the research on red meat is often on observational data and often does not distinguish between processed meats and unprocessed meats. So that may be an important distinction as well. And a lot of the research that just looks at unprocessed red meat does not find these negative health consequences. However, they're both in agreement that the overall dietary pattern is very important rather than just looking at whether somebody is consuming meat or not, right? We want to make sure that patients are following a whole food nutrition plan and that we meet our patients where they are. And again, I think there's so much more in common there than there is different. And the speakers certainly agreed to that too. And in addition to that, both of them do recognize that nutrition research is incredibly difficult to do. And a lot of the research that we have on nutritional is weak observational data, which doesn't really allow us to assess cause and effect. Our next speaker was John Jakasik, and he gave an update on the 2018 physical activity guidelines and for fitness and physical activity prescription in obesity. So again, he just iterated that physical activity by itself tends to result in about a 3% weight reduction, but that there is great variability between individuals and between men and women in their response to physical activity. And that certainly physical activity does increase the odds ratio of maintaining weight. So per the guidelines, for weight maintenance after significant weight loss or for more robust weight reduction, some people may need greater than 300 minutes of moderate intensity exercise per week. And we should also include resistance training for muscle mass. What he also pointed out is that faster walking speeds does increase the pressure on joints in patients with obesity, especially in the hips, knees, and ankles. So his recommendation was not to necessarily encourage faster walking, but to increase the intensity, do slower walking, but perhaps at an increased incline on a treadmill. And that may reduce the risk of musculoskeletal pathology. And of course, we want to make sure we're taking a good physical activity history, assessing activity levels, barriers, enjoyment, and progress physical activity gradually. You may hear some sounds in the background. They're doing some work at my house, so we're just going to ignore that, okay? And we'll just keep going. Next, we had another big giant in the field of obesity medicine. We had Dr. Lou Aroney speaking, and he discussed the pathophysiology of obesity and medications. And something interesting that he was talking about was some research that shows that fattening foods, processed foods, may actually be causing damage to the hypothalamic structures that control energy balance and may elevate the body's set point. So, and the interesting fact was this happens prior to weight gain. So a lot of times we know that there's inflammation with obesity, and that can damage the nervous system, including the hypothalamus, where we have our energy regulatory system. But this was interesting that they really showed that this inflammation in the hypothalamus happened prior to weight gain as a result of the types of foods that were being eaten. And he also shared, similar to what Dr. Harold Bays has shared in the past, that the evolution of the treatments of obesity is very similar to the evolution of the treatment of hypertension back in the late 70s, where at that time there were few treatment options. They were not widely used, just as we have with obesity right now. And hypertension was thought of as a behavioral problem of just simply too much stress. And now we see that, of course, we have over 100 different drugs in 10 different categories for hypertension. And we're really starting to see that the obesity treatment options are rapidly evolving. The evolution of anti-obesity medications are rapidly evolving. And just that it's a really exciting time to be in obesity medicine. And I think we're really going to see that this field is about to explode with a lot more treatment options for patients, which is wonderful. So, and he finishes with this quote: "What happens when you fill the treatment gap," and that treatment gap being between lifestyle and bariatric surgery, "let patients know you understand their problem and treat them in a non-judgmental manner." And he was able to show some really great examples of what happens when you approach obesity treatment in that way. It's a great presentation. The next presentation was also wonderful. It was Dr. Michael Davidson, and he talked about a heart-healthy diet and mentioned that it's time to rethink what a heart-healthy diet really is. You know, it started out with the 7-country study, which led to the low-fat paradigm, and it's really time to start rethinking that. And his recommendation is that patients with metabolic syndrome should be placed on a low-carb, higher-fat, higher protein diet, and that patients with high LDL with normal waist circumference may benefit from incorporating more protein. He also showed lots of studies that there was not a significant association between saturated fat intake and cardiovascular events, and that LDL is not related to red meat intake per se, and that only small dense LDL, which tend to increase with a high carb, low fat diet, is really the biggest risk factor for cardiovascular disease. He also compared low fat studies to low carb studies, and there are 27 head-to-head trials that look at either weight loss with low fat or low carb, and in only one of those 27 studies did they see a greater weight loss with low fat. 16 out of the 27 studies showed greater weight loss with low carbohydrate nutrition plans, and 10 out of 27 showed no significant difference. He did warn that ketogenic diets may increase LDL significantly in certain patients, those hyper-responders, particularly patients with the ApoE4 gene. So it's important, of course, that we're screening and making sure that we're following lipid panels on all of our patients. And again, it comes down to treating patients with a personalized approach, taking into account their metabolic profile, their taste preferences, their satiety, and where they are in their readiness to make changes. Next, we had Dr. Kirsten Knudsen, who talked about circadian rhythms and the importance of eating and sleeping in accordance to our natural human circadian rhythm. She also showed that when there is circadian misalignment, so when somebody might be getting enough sleep, but they're sleeping at the wrong time of the day or night, that there are actually differences in the effects between males and females when this happens. And again, some of these studies, the N was very small, only 6 women and 8 men in this study, but it was interesting that they showed differences in the hormonal responses between men and women. She also talked about shift work. We know shift work increases BMI, waist to hip ratio, diastolic blood pressure, insulin resistance, triglycerides, type 2 diabetes, and also looked at chronotypes. So those people who are the early birds versus the night owls. And unfortunately for those night owls, there are more health risks associated with being a night owl. So they do have increased morbidity and mortality. Then Andrea Bisbee, a psychologist, discussed the psychological and behavioral treatments for obesity. And she discussed using motivational interviewing, especially for those who are in ambivalence, cognitive behavioral therapy, really for everybody during the weight loss and the weight maintenance stage. And then acceptance and commitment therapy, also, especially for those patients who struggle with emotional eating or avoidance of physical activity. It really teaches patients ways to tolerate and accept emotional pain rather than trying to numb out or avoid those feelings. And last but not least, we had the amazing Dr. Robert Kushner speak to us about the assessment and management of post-bariatric surgery weight regain. And so he said that really, with the exception of anatomical failure, the determinants of post-surgical weight gain are very similar to non-surgical weight gain. And in general, whether somebody had bariatric surgery or had non-surgical weight loss, there's an average of about a 30% weight regain from the lowest weight, whether somebody had surgical weight loss or not. And it's really important, he emphasized using weight graphs to really hear our patients' stories and recognize patterns, and then to be able to address whatever specific issues that patient is dealing with that appears to be contributing to the weight regain. He also noted that behavioral and lifestyle therapies, studies have shown that there's fairly limited benefits on this post-operative weight regain, and that pharmacotherapy, however, does appear to be promising and should be considered as an adjunctive treatment, along with identifying and addressing, again, the etiology of the weight regain. So that's trying to summarize a whole day of CME in just a few minutes. So I hope some of this was helpful to you. I'm going to be out next week, so I will see you all back again in 2 weeks. Again, if you are somebody who is considering starting or has started an obesity management program, or you have one and you're looking for ways to optimize, be sure to check out gaininghealth.com for the resources that we have for you to help you with this process and to save you a lot of time and energy. So that's it for now. I will see you back in 2 weeks. All right, take care, everyone. Bye.